went to get the recorder. Can you see it now?
Not yet.
Wow, are you sure?
I think it's
What
your
I think
network.
it's your network, Dr.
We can
Funke.
see.
Okay, I'll log out and log in.
what about now? Hey, I know my network is
Probably we can see your network. Probably we can see you.
okay. So the oncogenic microbes, we mentioned Epstein-Barr. Epstein-Barr is a vital one that we need to remember. Most of them are viruses. We only have one bacteria and two parasites. So not parasite, rather the protozoa. So we have the worms rather, not even protozoa, the worms, the liver fluke and the schistosoma. So one uh one bacteria, the worms, and the others are viruses. So um so Epstein-Barr is the first one that we are looking at, and when it comes to Epstein-Barr, we want to remember four different malignancy. Epstein-Barr as a virus typically infects CD21. So anything that contains CD21 can get infected by Epstein-Barr virus. And what we talked about in our immunology, we said there are some immune cells that contain the CD21 marker. An example of such cell is the B cells. So because of that, the Epstein-Barr virus can get can enter into those B cells and can stay latent in them. And over the time, it can cause malignant transformation of those cells. So it can affect B cells and cause Burkitt lymphoma. So it can cause this chromosome 18-14 translocation. So by the time we start talking about those things in hematology, it will become clear to us. So we can't go into those details now, but we should know that it can drive so many chromosomal translocation in some B cells, which could be 814, 28, 822, and it will cause Burkitt lymphoma. So, Burkitt lymphoma, proliferation of B cells in certain areas of the body, like the jaw, the abdomen, depending on the type. So, we should always remember that Epstein-Barr virus is implicated in causing Burkitt lymphoma as well of the abnormal proliferation of the B cells. It can also cause Hodgkin lymphoma due to affectation of the same B cells. And before I leave this Burkitt lymphoma, I want us to know that Burkitt lymphoma is a form of non-Hodgkin lymphoma. So Epstein-Barr virus can cause both Hodgkin lymphoma and non-Hodgkin lymphoma. And the basis for all this Hodgkin, non-Hodgkin is just when you are able to appreciate the presence of the Restenbach cells. So Restenbach cells are just cells that have appearance like that of a hole. So they have this double nuclei. By the time we get to hematology, we'll talk more about them. So any cell that you see, any tumor with those Restenbach cells, they are Hodgkin lymphoma. Hodgkin lymphoma. So those ones that don't have it, the non-Hodgkin lymphoma. An example of a non-Hodgkin lymphoma is Burkitt. So Epstein-Barr can cause non-Hodgkin lymphoma like Burkitt and Hodgkin lymphoma itself. Then we said it is the only virus that is are capable of infecting the nasopharyngeal epithelium, and it can cause nasopharyngeal cancer. So we should not forget that Epstein-Barr is the only virus that can cause nasopharyngeal carcinoma. Then we said it can also infect the B cells that are found within the brain, and it can lead to primary CNS lymphoma. So this is not due to metastasis. If there is metastasis from other parts of the body to the brain, then we can have secondary CNS lymphoma. But such metastasis is not likely to come from EBV. So the typical way they like asking this primary CNS lymphoma is when they tell you that on brain CT or MRI, you're able to appreciate a single ring enhancing lesion in the brain. So when there's a single ring enhancing lesion in the brain, we are thinking of primary CNS lymphoma from Epstein-Barr viral infestation. And it is very common in people that are immunocompromised, particularly people with HIV. Those are those kind of people that are predisposed to having this primary CNS lymphoma. And because of the fact that people with HIV can also have other things, other brain enhancing lesions like toxo, neurocystic psychosis, and other things. So uh, those ones will typically present with multiple lesions. It's usually multiple, but an individual with primary CNS brain enhancing lesion, we are thinking of primary CNS lymphoma from Epstein-Barr viral cause. So the non-Hodgkin is Burkitt, the Hodgkin, normal Hodgkin lymphoma, nasopharynx, nasopharyngeal carcinoma, then the brain, primary CNS lymphoma. Then hepatitis B and C can cause hepatocellular carcinoma. Those are the only viruses that can cause chronic hepatitis. And from chronic hepatitis, it can progress to cirrhosis and lead to hepatocellular carcinoma. So we should not go and pick hepatitis A or hepatitis E. Those ones cannot cause chronic infection. It is only B and C that is capable of causing hepatocellular carcinoma. Then the next one is human herpes virus 8. So I said the way we can always remember this is just to name it the Kaposi sarcoma virus. That's how I remember it. So Kaposi sarcoma virus is human herpes virus 8. It is a sexually transmitted virus that is very common in people with HIV. So people with HIV typically have this cancer. So human herpes virus 8 is implicated in causing Kaposi sarcoma, which is like tumor of the endothelial cells, particularly within the lymphatics. So if there's a malignant transformation of the endothelial cells lining the lymphatics, you have Kaposi sarcoma. They appear purplish. They usually appear purplish. They are nodular in appearance, and you typically see them in the skin. So once you see purplish nodular lesion in the skin in someone that has a background immunosuppression, you are thinking of Kaposi sarcoma. By the time we start doing the dermatology, we're also going to talk about the comparison of this sarcoma with other close differentials like bacillary angiomatosis and other things. So that's the way you typically see it. Purplish lesion, background immunosuppression. You are thinking of Kaposi sarcoma. So aside that, the human papillomavirus, particularly the serotype 16 and 18, are also implicated in causing malignancy. And we said because this guy is sexually transmitted, and it is number one, it is predominantly known for causing cervical cancer. That's when you talk about human papillomavirus and you are relating it to malignancy, the first thing that we should always say is cervical cancer. That's what it is known for. That's what it is known for. And because of the fact that human papillomavirus can be sexually transmitted, so if a guy have a sexual intercourse with somebody that has this human papillomavirus, the person can acquire the infection. And of course, men don't have cervix, so they can develop penile carcinoma instead. Penile carcinoma. So, and one thing I want to mention about human papillomavirus is that its own malignancy form is squamous cell. Squamous cell cancer of anything. So anything that affecting. So the cervix is going to cause a squamous cell carcinoma of the cervix. That is cervical cancer. So the penis of the person that had sexual intercourse, the person can develop penile carcinoma, squamous cell type. So people that are practicing oral anal sex, they can also develop the anal carcinoma form as well as the head and neck cancer. So head and neck squamous cell carcinoma, anal squamous cell carcinoma, penile squamous cell carcinoma, cervical squamous cell from human papillomavirus, serotype 16 and 18. By the time we are doing respiratory, we are going to talk about the other serotype of HPV that can cause other malignancy. But for now, let us stick with this. So the next one is a bacteria, which is Helicobacter pylori. We said this guy can cause chronic infection in the stomach because it acts so many factors that can allow you stay within the environment of the stomach undetected, undisturbed, without any immune response to it. It's just colonizing the stomach, and with that, it can cause chronic gastritis. So from chronic gastritis, it can now progress to cause the gastric adenocarcinoma. It's going to be adenocarcinoma because within the stomach, we have gastric glands. Gastric glands are there that contain so many cells. The chief cells, the chromaffin cells, the all the other cells that are in the stomach. So yeah, parental cells and like. So those glands can undergo malignant transformation and they are going to develop into adenocarcinoma. So we cannot say squamous cell carcinoma here. Adenocarcinoma because the stomach contains glands. So when there's epithelial transformation of those glands, when there's malignant transformation of the epithelial cells lining those glands, there's going to be a gastric adenocarcinoma that is going to start. And we said the stomach is one of those mucosa that contains lymphoid organs. Yes, The stomach is one of them. So there's something we call the mucosal arterial lymphoid tissue. So those cells that are there, those B cells, those T cells that are there, can undergo malignant transformation, and it will lead to mucosal arterial lymphoid tissue lymphoma. H. pylori is responsible for that. We should not forget these two. Very important for H. pylori. Gastric adenocarcinoma and mucosal arterial lymphoid tissue lymphoma, H. pylori. Because this mucosal arterial lymphoid tissue is most abundant in the stomach. So then from the name, human T lymphotrophic virus 1. So T cells, that's what it predominantly infects. So it can cause the adult T cell leukemia or lymphoma. This one too is well, it can also occur in people with HIV. But one thing I just want to say about it is that it belongs to the same family as HIV. So both of them belong to the retrovirus. It's very similar to HIV. Human T, it's not a very common virus that we talk about. So that is why we still need to pay special attention to it, because it's not something that everybody commonly know. Yes. So we have to pay attention to it. The human T lymphotropic virus type 1 causes the adult T cell leukemia lymphoma. So there is malignant transformation of the T cells, predominantly the T cells, not the B cells like in Epstein-Barr, causing Burkitt lymphoma and the Hodgkin and the other ones, but the T cells now. Then the worms, the liver fluke, chronic sinus, which we said that it is bile loving, so it likes to stay where there is bile. So that's why we call the liver fluke. Yes. So it can cause irritation of the biliary epithelium, particularly the common bile duct, and it can lead to cholangiocarcinoma. So cholangiocarcinoma is malignancy of the epithelial lining of the bile duct from liver fluke, chronic sinuses. So we should pay attention to this one too. Very important. So there's Schistosoma hematobium, which is one of those Schistosoma species that typically infect the bladder. So we have other ones that affect the colon. So, but this one is the hematobium. This is the one that stays in the bladder. Schistosoma hematobium, and it causes squamous cell carcinoma of the bladder, because it can cause irritation of the bladder mucosa. So when it irritates the bladder, particularly the eggs that they lay, from there it's going to cause a metaplastic change of the bladder epithelium from the transitional or the uroepithelium to the squamous cell epithelium. So from the metaplasia, they can progress to dysplasia, then they can now cause malignancy. So another thing that can cause squamous cell bladder cancer is smoking. Yes. So we should not forget that. So the tumor markers, we said there are some things that we call the tumor markers that helps us monitor response to therapy, as well as to investigate if there's any recurrence. So we said you don't use tumor marker to make diagnosis or to screen, because we said there are so many things that are non-neoplastic that can still cause elevation of these tumor markers. So they are not very sensitive, or they are not very specific for malignancy, but you can use them to assess response to therapy. That is, you've made diagnosis of your malignancy. There's malignancy there. You just want to know. And of course, if there's a malignancy, you expect elaboration of these markers. So you want to know, and you expect that, okay, there's a malignancy, there's elaboration of these tumor markers. If I'm giving treatment, if I'm offering treatment to debulk this malignancy, I expect a drop in the level of this tumor marker. So it makes sense. So that's why we use it to assess response to therapy. And when you are able to achieve complete remission, complete resolution of that malignancy, there's going to be a drop or disappearance of these tumor markers in the blood. So if it now reappears again after a situation where you don't have any level before, a total reduction, and later you start noticing appearance of those markers, you can say there's a recurrence. So you can use the tumor markers to assess response to therapy, as well as to check for recurrence. But you can't use it to make diagnosis or screen, because there are so many neoplastic things that can cause the elevation of the markers. So the first one is alkaline phosphatase. We said this one is predominantly present in the bone, in the liver, the placenta. The bone, the liver, the placenta. So because of the fact that we can see it in the liver, someone that has cholestasis predominantly, so obstruction of the extrahepatic duct or the intrahepatic duct, cholestasis, intra or extra. When there's a cholestasis, there's going to be elaboration of this alkaline phosphatase. So it's very specific. It's very, very specific for that. Although it can also be elevated when there's hepatitis or hepatocellular carcinoma. That is why you do not only make diagnosis of cholestasis with checking your alkaline phosphatase. You need to combine it with another thing, and that is the gamma glutamine transaminase or transferase rather. Gamma glutamine transferase. So that's another enzyme that you want to combine with the alkaline phosphatase to assess for a problem with the liver. So by the time you're able to collaborate these two, you can say that this is a pure cholestasis. Because in someone that has hepatitis, that is not cholestasis. There's just inflammation of the liver, no obstruction to the duct. There's no obstruction to the duct. The person can still have elevation of alkaline phosphatase. But once you are seeing elevation of GGT with elevation of ALP, that is cholestasis. That is cholestasis. That's that about the liver. Then we said it can also be expressed in the bone. So if there's a metastasis to the bone, or if there's a remodeling of the bone, so someone that has a bone tumor, they can have elevated ALP. So someone that has a Paget disease, so Paget disease, we are going to talk about that when we start musculoskeletal. So it's more like a disease that is actually with remodeling and degradation of the bone. So we are breaking down the bone and we are now constructing it again. So it has different phases. The lytic phase where we are destroying it, the blastic phase where we are reconstructing it, then the mixed phase where both of them are happening together. At the end of the day, the bone that's going to be formed is not going to be this typical bone that exists. So that one is going to be very fragile. It can fracture easily. So because of the constant remodeling, synthesis, breakdown, there's elaboration of alkaline phosphatase. So it's increasing there. Then for the placental, so someone that has a seminoma is a germ cell tumor of the testes. So because of the fact that those seminomas, they can behave as if they are from the placenta, so they tend to elaborate some placental hormones. One of them, the placental alkaline phosphate, that's the PLAP. So once you see PLAP, you want to think about seminoma. So because of the fact that it can behave like a placenta, it also expresses HCG. So the two hormones that you can see for seminoma includes the PLAP and the HCG. Although that one might not be very relevant for us now because we are not yet doing reproductive, but if you can remember it, it's fine. So seminoma can elaborate PLAP, which is placental alkaline phosphatase, as well as HCG and LDH. Let's just learn those three. HCG because of the fact that it can behave like placenta, and HCG is typically secreted from the placenta. The schistosophoblasts of the placenta secrete HCG. Then the PLAP, then LDH. So LDH, because of the fact that the female equivalent of seminoma is dysgeminoma, and dysgeminoma are found to elaborate LDH. So the male version, to which is seminoma, also does the same, elaborate LDH. But the major clincher for seminoma is the PLAP. Alkaline phosphatase, we are complete. PLAP, Paget disease, bone problem, liver issues, alkaline phosphatase. So just remember where it's from. The liver, the bone, and the placenta. You'll be able to figure out everything about alkaline phosphate. Then alpha fetoprotein. Alpha fetoprotein is secreted by the liver as well as the yolk sac. So it makes sense for someone that has a yolk sac tumor or the endodermal sinus tumor to have elevation of alpha fetoprotein. Because of the fact that it's produced on the liver, there's high release of it in a liver that has undergone malignant transformation, hepatocellular carcinoma. So they start behaving as if they are still in the embryonic phase, and they start releasing alpha fetoprotein. Hepatocellular carcinoma, alpha fetoprotein. Very, very important. Very, very important. We should not forget that. It's one of the clinchers for hepatocellular carcinoma. Once they put it in the option, you go for it like it's very, very direct for it. What you are seeing features of hepatocellular carcinoma, you are seeing jaundice, hepatomegaly, tender hepatomegaly again, polycythemia, and all those things. Then there's elevation of this guy. You know that is hepatocellular carcinoma that they are talking about. Endodermal sinus tumor is also a tumor of the germ cells that is non-seminomatous. So when they say the non-seminomatous germ cell tumors, that is the germ cell tumor that is not a seminoma. Endodermal sinus tumor is one of them. the secret alpha fetoprotein. So I'm sorry we are going into all these things. That's the way it was arranged in the book, and we have no choice. We have to talk about it. I just don't want to abandon it. That I will now say that it's when we start doing all those things, because it's very, very difficult to be linking all those. So once we're able to remember little now, by the time we get to all those systems, we'll be able to, you know, um, consolidate them. So mixed germ cell tumor just means when you have two type of germ cells. Maybe you have endodermal sinus tumor and choriocarcinoma, or endodermal germ cell tumor and seminoma. Yes, so that's a mixed germ cell tumor. So it means that for somebody to have a mixed germ cell tumor and be elaborating alpha fetoprotein, it means that a yolk sac tumor must be mixed with another one. So that is just the clincher there. So once you're able to figure out that endodermal sinus tumor or yolk sac tumor can cause elevation of alpha fetoprotein, you will know that a mixed germ cell tumor too can cause that if it contains yolk sac tumor. That is it. Neural tube defect is also another condition, and the pathophysiology of neural tube defect causing alpha fetoprotein elevation is the same as abdominal wall defect. So both of them, abdominal wall defect like omphalocele, like gastroschisis, as well as the neural tube defect, they both create opening for the alpha fetoprotein that is produced from the yolk sac of the fetus to escape into the amniotic cavity, then find its way to the placenta, then to the maternal blood. So that is why it is elevated, because if it does not, if there is no what's it called, if there is no neural tube opening, if there's no abdominal wall opening, you'll not be able to find escape of that um marker into the amniotic cavity, then into the maternal blood. But because there's an opening for it to pass through, so it's going to find its way to the amniotic cavity. So by the time you check for this alpha fetoprotein in the amniotic fluid, it will be elevated. Normally it should not be elevated. It should not be elevated. Yes, because what is typically forming the amniotic fluid is what is anybody, old guys, what is typically forming the amniotic fluid?
Urine.
Baby's urine.
Baby's urine.
So
The
it should be the
urine.
urine. It should be the urine. So the blood is not contributing to formation of the amniotic. It's not the blood, but urine. So it should not be elevated in the amniotic fluid. But because of that opening, it can enter into the amniotic fluid, and it can even go to the maternal circulation. So that is why abdominal wall defect and neural tube defect, there's elevation of alpha fetoprotein, but it is down in someone that has Down syndrome. It is down in Down syndrome. So we don't actually know the reason why it's elevated in ataxia telangiectasia, but it is elevated in ataxia telangiectasia. That's the A that is elevated in ataxia telangiectasia. The other A that is reduced in it is AGA. So IgA is reduced, alpha fetoprotein is increased. IgA is reduced in ataxia telangiectasia. So it is not only in IgA deficiency that there's reduction in IgA. That's another thing to pay attention to. That's why you have to marry all these symptoms together before you go for it. Just don't see in the question that IgA is reduced and we'll be looking for IgA deficiency. You have to complete the story, look at what they are talking about, and be sure that it's not ataxia telangiectasia. Yeah, because they might put it there that the person is having spinal angioma, some spider-like lesions. The person is having abnormal gait and is having IgA deficiency. Some of us might rush to pick IgA deficiency. That is not IgA deficiency. That is encompassing more than IgA deficiency. It's involving another thing. So that is changing diagnosis to ataxia telangiectasia. There's a telangiectasia, which is a spiral like dilatation of the vessels, and we're also seeing problem with gait, which is ataxia. So that is that. So HCG is from the placenta. So anything that affects the placenta is going to elevate HCG. So predominantly someone that has idatiform mole or choriocarcinoma. Those are conditions that affect the placenta. Like they are like neoplastic growth of the placenta. So choriocarcinoma is metastatic. The idatiform moles are still benign. So they are both called the gestational trophoblastic disease. In someone that has a testicular cancer, we give example. So what testicular cancer can cause elevation of HCG now?
Seminoma.
Hello?
Seminoma.
So a seminoma. So it makes sense for testicular disease to be able to cause HCG elevation because of seminoma. mixed germ cell tumor, particularly the one that is mixed that contains the seminoma. That's it. So then I mentioned the markers, the CA marker 53, 15.3 rather, 19.9 and 125. So you might not need to memorize the full name. Just know 15, 19.9 or 19, 125. So 125 is ovarian rather, ovarian epithelial tumor. Ovarian epithelial tumor is CA 125. CEA is the colon one. CEA, that's the carcinoembryonic antigen, is the colon one, while the CA 125 is epithelial ovarian cancer. Yes. So CA19 is pancreatic adenocarcinoma, CA15 is breast cancer. It's very, very unlikely that they will be putting all these markers only in the question. It's very unlikely. They're still going to put other clinicals to make the diagnosis. And I'm sure that by the time you even read the history, you'll be able to make the diagnosis without even looking at the marker. That's how USMLE can be. They're not that wicked. Yes. So calcitonin is from the medullary thyroid carcinoma, like we can see now. So I'm saying it now again, we should not forget to. Calcitonin is from medullary thyroid carcinoma. Yes, it can also be responsible for causing amyloidosis. Calcitonin, medullary thyroid carcinoma, and it is part of the MEN2A, the MEN2B. So MEN2A consists of medullary thyroid carcinoma and pheochromocytoma. MEN2B also consists of medullary thyroid carcinoma and pheochromocytoma. So both of them can be associated with elevation of calcitonin. CEA, we've talked about that, colorectal and pancreatic. So most of the time is colorectal, but pancreatic too is one of them. So pancreatic, colorectal, those are the malignancy that can be associated with elevation of CA. Forget about the others ones. There are so many things to learn. You should not be complicating those things. So most importantly, carcinoembryonic antigen is for colorectal and pancreatic cancer. Chromogranin. We mentioned chromogranin the other time to be specific for the neuroendocrine tumors. Tumors that contain neuroendocrine cells that are capable of discharging hormones as well as neurotransmitters. So an example of the one that releases neurotransmitter, pheochromocytoma, it is a neuroendocrine tumor. An example of a tumor that arises from neuroendocrine cells that is capable of releasing hormone, small cell carcinoma of the lung. Because small cell carcinoma of the lung can release, what are the two things that we said that small cell carcinoma can release? Anybody? Small cell carcinoma of the lungs. What are the two parameters?
ADH and ACT.
Yes. So ADH and ACTH, the two A's, ADH and ACTH, those are hormones. And again, it precisely comes from the Korchisky cells of the liver. So there's something we call the Korchisky cells of the lungs. Yeah. Okay. Yes. So the Korchisky cells of the lungs, that is where the small cell carcinoma comes from. So it can cause some elaboration of some hormones like ADH and ACTH. And don't forget, it is an example of a neuroendocrine tumor. Please, it is an example of a neuroendocrine tumor. So squamous cell is not an neuroendocrine tumor. It doesn't come from any neuroendocrine cells. And again, it does not even elaborate any hormone. What it elaborates is what? Parathyroid related peptide. Yes, so that is not an hormone. Parathyroid related peptide is a protein that can function like some hormones. Yeah, so don't get it treated. So small cell carcinoma is a neuroendocrine tumor. Pheochromocytoma is another one. Neuroblastoma is another one. Insulinoma is part. Glucagonoma is an example. Both of them, all of them rather, can secrete chromogranin. LDH is particular about dysgeminoma. So I said it. Once you see LDH, you think about dysgeminoma. Dysgeminoma, and the male equivalent of dysgeminoma is what? Seminoma. So both of them can elaborate LDH. So you can see it in testicular germ cell tumor like seminoma and in ovarian dysgeminoma. So both of them can cause LDH. Anybody remembers the appearance of dysgeminoma? Old guys, what's the appearance? I know that one might be very hard for us to recall. We might need to revise it. But do you have anybody that remembers? On histology, what do you see? This geminoma. Is Dr. Suliat here? Dr. Dr. Adiola, do you remember? This is geminoma. Dr. Francois. So, someone that has a this geminoma, what you
Fried
see?
egg cell, abi?
Yes.
Mm,
So what do you see in the fried egg appearance? Fried egg appearance, this geminoma. Fried egg, this
I
geminoma.
thought about it, but I wasn't sure. Wow. Okay. Thank you.
Yeah. So, and it's an indicator for tumor body. Yes, we said it that it's for tumor body because these cells they have high amount of this guy because we talked about the Warburg effect. They want to produce a lot of molecules to serve as a source of the carbon origin for them. So the lactate dehydrogenase is what is converting their pyruvate to lactate, then from lactate back to pyruvate. So it's highly active in them. So the more the tumor cells, the more the activity of this enzyme, and you can say that that's actually a very high tumor load. So based on the level of the LDH. So it's for analyzing the tumor body. Neuron specific enolase is just a tumor marker that we can use to um, monitor the neuroendocrine tumors too, but not generalized like chromogranin. This one is specific to just three. So from the name NS, so NS, so the N neuron specific. The N is for the neuroblastoma, the S is for the small cell lung cancer, and the C is for the carcinoma tumor. So NSC, so we can just say neuron specific. So neuron, the first letter, the first letter of the S, the first letter of the N, the neuron, first letter N, second letter, which is specific, the first S, then the last letter C. So I think that's the way we can remember it. So neuron, first letter of neuron N, the first letter of specific S, this last letter of specific C. So neuroblastoma, S, small cell carcinoma, then the C, carcinoid tumor. The three of them can elaborate neuron specific enolase. Then PSA is very straightforward, prostate cancer. That is it. But it's just that in PSA test, it can also be elevated in
Sorry,
other.
what's the third thing you said?
For what?
For NSC.
C is the carcinoid tumor. Please, can you guys see my screen? Because all this thing I'm saying is on the screen. Oh. Please, you guys should be looking at my screen. Oh.
Okay,
Please don't listen.
okay, I can see it now.
Okay. So PSA, prostate specific antigen, is also elevated in prostate cancer as well as BPH and prostatitis. BPH and prostatitis. BPH and prostatitis. So the three of them, BPH, prostatitis, prostate cancer can all elevate PSA. It's just that there's a level for PSA elevation that you can use, to establish malignancy. Yes. So what are the immunochemical stain? So these are just the stain that you just use to um determine the origin of a
Dr.
tumor.
Bali,
Yes, Dr. Precious.
sorry, before you continue, please. You said HCG is from placenta. I can't remember the reason why the reason you gave for seminoma producing HCG again.
So we said it behaves like placenta. So those cells behave like placenta. So they tend to secrete all those things that placenta secrete. Do you understand?
Okay. Thank you.
Yes. So important immunohistochemical stains. Those ones are used to figure out the origin of a particular tumor, particularly when it is metastatic. So you see a tumor somewhere and you are not sure that that tumor is from that premise site. You are thinking it's coming from somewhere else. So you can stain it with the use of this immunochemical stain to know the kind of stain it picks. So the stain it picks can tell us the origin. So anything that stains positive for chromogranin and synaptophysin, both of them are combined to make diagnosis of neuroendocrine cells. The NCE, neuroblastoma, the carcinoid tumor, and the small cell carcinoma of the lung. So I don't want to bother explaining to us the features of this tumor. Like we are just going to be saying too many things. So by the time we get to all those areas, we'll talk more about them. Chromogranin and synaptophysin, NCE, NCC rather. what am I saying? NSC, neuroblastoma, small cell carcinoma of the lung, then the carcinoid tumor. Cytokeratin is for epithelial cells. Epithelial cells is for cytokeratin. So epithelial cell tumor like the squamous cell carcinoma and the other ones. Anything that has carcinoma, they can stain positive for cytokeratin. Yes. So um desmin is for muscle. So desmin is in the muscle, muscular tumors like rhabdomyosarcoma. So we said the glial fibrillary acidic protein is for astrocytes. So anything that contains the astrocyte, like astrocytoma and glioblastoma, that's for glial fibrillary acidic protein. And we should not forget that astrocytes are neuroglia. So for people that have not done neurology, you might not be able to figure this out, but it they are neuroglia. Neuroglia are they are supporting cells of the brain. So they are not the neuron, they are just structures that are supporting the neuron. They are cells that are supporting the activity of the neuron. So there's another one that we call the neurofilament. That one is for neurons. So any neuronal tumor that's primarily from the neuron, not the glia of the neuron, but the neuron itself, like neuroblastoma, neurofilament will be positive for them. PSA, prostatic cancer, I've said that. PCAM and ICAM, because these guys are found within the endothelial cells. So vascular tumor, like someone that has hemangio, like someone that has angiosarcoma. So you can think of any vascular tumor. It can be hemangioblastoma, angiosarcoma, and all those things. Something that comes from the endothelial cells. PECAM will be positive in there. S100, we said this one is from the neural crest. So S100 in the neural crest cells, X100. So what are these things we are talking about? Melanoma. So I gave us the acronym then, Elmo passes. So we should just remember melanoma and schwannoma. I think we are okay. Nobody will be asking us this or that thing. So melanoma is from the melanocytes are from the neural crest. The Schwann cells are from the neural crest. So both of them can undergo malignant change and they will be positive for this S100. Then the only one that is not from the neural crest that is positive for S100 is what? The Langerhans cells histiocytosis. We are going to talk about this when we get to hematology. Langerhans cells. I hope you remember the Bibek granules. Where do we find the Bibek granules? The old guys. Bibek granule that looks like tennis racket. Okay, so trap, that's tartrate resistant acid phosphatase. Tartrate resistant acid phosphatase is peculiar to hairy cell leukemia. So we said two things we want to always remember for hairy cell leukemia: trap and BRAF. Trap and BRAF. BRAF is the mutation that can cause it. Trap is a stain that is positive in someone that has hairy cell leukemia, because it's been found that these guys elaborate a lot of acid phosphatase, which is an enzyme that cannot be degraded by tartarate. So that is that about hairy cell leukemia. Trap and BRAF. Trap and BRAF. BRAF is the mutation, trap is the marker. Vimentin. Once you see vimentin, mesenchymal tissues. Just think about any mesenchymal tissues. Mesenchymal tissues for vimentin. Then we talked about P glycoprotein, that it's just an ATP dependent efflux pump that is used by malignant cells, that is used by cancer cells to pump out chemotherapeutic agents so that they can be resistant to them. So this P glycoprotein is also known as the multi-drug resistant protein 1. So any tumor cell that expresses this guy, if you administer chemotherapy, it will be resistant to that chemotherapy because they'll pump it out. They'll pump it out, and with time they will develop resistance to it. They will not respond to it because of that effect. So always remember that for P glycoprotein. It's being expressed in some tumor cells, and it is a pump. P glycoprotein is a pump that is ATP dependent. Does it, do you remember any other process that we've mentioned in this pathology that is ATP dependent? Anybody?
Apoptosis.
Apoptosis. Apoptosis. So P glycoprotein activity is ATP dependent. They use it to pump out those toxins out of the tumoral environment and they become resistant to it over time. Cachexia is when we have wasting of muscles. And we said it's due to any chronic condition that can elaborate TNF alpha, interleukin 1, interleukin 6. Me, once I remember those three, I'm okay. Yeah, but if you want to remember the four, but the most important one is TNF alpha and interleukin 1. Those are the most important ones. So TNF alpha, interleukin 1, interleukin 6, gamma interferon. So there are two postulations. TNF alpha and the other ones can directly activate this ubiquitinine system, the ubiquitinine proteasomal degradation. So it just start labeling all those proteins in the body for proteasomal degradation via the ubiquitinine pathway. So they can do that directly. They just start labeling all the proteins, particularly the muscle protein, and they start breaking down those proteins, leading to atrophy. Or because of the fact that TNF alpha and the other ones have appetite suppressing effect. So people that have chronic disease like cancer, like HIV, like heart failure, COPD, they have a lot of these interleukins in their circulation, and they act on the hypothalamus and suppress the appetite center, and they don't feel like eating. Because of that malnourished state, they have weight loss. They are not eating, they will lose weight. They are not eating, they don't have energy, they are fatigued. And of course, if there's loss of nutritional supply, which of the adaptation mechanism will be activated when there's no nutritional supply?
Atrophy.
Atrophy. Atrophy. So that is why there's muscle atrophy. You need to take them down through the ubiquitin pathway. Atrophy. So that is that about cachexia. So once there's muscle atrophy, weight loss, fatigue, in response to release of interleukin from that chronic disease that is causing those things, that's what we call cachexia. So you must be able to understand the pathophysiologic basis of cachexia as being due to elaboration of the cytokines in that chronic disease state. So just think of any chronic DM is the same thing for all chronic disease, diabetes, HIV, SLE, anything you can think of that is causing cachexia, the same principle. The interleukins are involved. So what are paraneoplastic syndromes? Quickly. So paraneoplastic syndromes are they are like manifestations that are associated with malignancy. So manifestations that are associated with malignancy usually due to elaboration of cytokines, hormones, or like growth factors from that malignancy acting on a distant site. So it is not due to mass effects from the malignancy, no. It is due to elaboration of some cytokines, some growth factors, some hormones from that tumor. And we can classify them based on the system that's affected. So for the musculoskeletal and the cutaneous one, we have 4 types: dermatomyositis, acanthosis nigricans, lesser-trelatan, and hypertrophic arthropathy. So dermatomyositis, you must always remember ovarian adenocarcinoma, very important stuff. You can see it. Ovarian adenocarcinoma, dermatomyositis. So the typical way the question will come is they can paint a history of presentation with this dermatomyositis. They can tell us somebody has progressive proximal muscle weakness. So the person cannot climb stairs because there's problem with the hip muscles. It's a proximal muscle of the leg. The person cannot comb the hair because there's weakness of the shoulder muscles. So the person cannot unbutton all those basic activities that involve the proximal muscles of the extremities. Weakness like that, dermatomyositis is on the way. Now, because that can either be dermatomyositis or polymyositis. To now make it specific for dermatomyositis, you see some typical rash, which includes the Guttron pappus and the helicobacter rash. So this erythrope rash is like an erythematous rash in the eyelid. It occurs typically in the sun-exposed area of the face. So you see that erythematous rash in the eye. Then the Guttron pappus, they are like papular erythematous rash at the back of the fingers. I showed us a picture that day. So you see it at the typically at the knuckles, at the back of the extensor surface of the hand, at the back. That's why you see those. That's why you see those Guttron pappus. So by the time we are combining the Guttron pappus, the helicobacter rash, and the myopathy, you can make your diagnosis of dermatomyositis. And those rash are typically present because of elaboration of some cytokines by the ovarian adenocarcinoma. Somebody can have dermatomyositis without ovarian carcinoma. But if there's presence of dermatomyositis in the setting of ovarian carcinoma, that is a paraneoplastic manifestation of that tumor. So that is it. So, yes. So you can see one of these in your exam. I cannot remember the one I saw, but I know I saw one. And the next thing was, what is this? Is it paraneoplastic? Is it metastatic? Is it they'll put some very confusing options there. So once you are able to figure out all these paraneoplastic manifestations, you know the answer to pick. So dermatomyositis is one of them. Acanthosis nigricans is another one. So acanthosis nigricans and lesser-trellat sign. Once you see these two, you are thinking of a gastric adenocarcinoma. I know that lesser-trellat sign is encompassing GI, but most of the time they come with GI problem. They can come with colon, fine. They can come with pancreatic, fine. But majority of the time, it is from gastric adenocarcinoma. So that's why but although I know they try to open it, visceral malignancy, it's good to know it. But in most of the cases, there's going to be a background gastric adenocarcinoma. Gastric adenocarcinoma, acanthosis nigricans, and lesser-trellat. So what is acanthosis nigricans? When there's presence of hyperpigmented valvety, wart-like plaques in the intratriginous area of the body, like the neck and the axilla. So that one is actually coming from elaboration of some growth factors, epidermal growth factors from the tumor. It's now acting on those areas and it's making them hyperpigmented. So they are looking thickened. Once you see that, acanthosis nigricans, gastric adenocarcinoma. Lesser-trellat sign is collection of so many seborrheic keratosis. So seborrheic keratosis is like a skin lesion that it can be flat, it can be nodular, but the typical way that they will present, that they will mention in the question, they will tell you that it's greasy, it's oily. Once you are seeing that, you are thinking of seborrheic keratosis. So when you have them in abundance, so let's see the way it looks like. Seborrheic keratosis. So seborrheic keratosis, you see the dark spots, they look very brownish. So exactly, so this is it. So once you see accumulation of seborrheic keratosis in the body, that is GI cancer or visceral malignancy, or specifically GI cancer. Once you see acanthosis nigricans, thickened stuff in the armpit that's looking brownish too, so you know that is acanthosis nigricans. So yeah, exactly. So this is one. This is one we also saw that day. So this is acanthosis nigricans. So GI malignancy. Dermatomyositis, ovarian adenocarcinoma. Dermatomyositis, ovarian adenocarcinoma. Acanthosis nigricans, armpit issues, as well as lesser-trellat sign. So accumulation of seborrheic keratosis, we are thinking of gastric adenocarcinoma. Those are the skin paraneoplastic manifestation. Then the last one is hypertrophic osteoarthropathy. So this one is just lung cancer. Very common with lung cancer. Very common with lung cancer. Sorry, people, please give me 2 minutes. I want to attend to something. 2 minutes. Two minutes. I want to attend to something, please. 2 minutes. 2 minutes. Okay. So, hello, are you guys still there? Can you guys hear me?
Yeah.
Okay.
Yeah.
So, for the Hypertrophic osteoarthropathy. So you want to think of adenocarcinoma of the lung. Adenocarcinoma. So it's if it's going to be a neoplastic manifestation, a paraneoplastic manifestation rather, is going to come from adenocarcinoma of the lung, and it is due to elaboration of some um, cytokines by this cancer, so which typically cause sequestration of the megakaryocytes at those areas. So when those megakaryocytes come there, they also when they get to that area, rather, they also start releasing some cytokines that lead to vascular proliferation as well as proliferation of the bone. So there is peristalsis. So this peristalsis actually can also mean um, peritonitis, inflammation of the bones, the peristome of the bone. So there's proliferation of the vessels there. There's proliferation of the peristome of the. There's inflammation of the peristome of the bone. So at the end of the day, the bone will have this club shape appearance. There's going to be pain at that area. It's going to be painful because of the ongoing inflammatory response. There can be effusion from damage to the vessels and leakage of plasma into the area. But all in all, everything is going to culminate in clubbing of the fingers, and that is due to adenocarcinoma of the lung. So, uh, so that's that about hypertrophic osteoarthropathy. So, for the endocrine one, we have three types: hypercalcemia, the Cushing syndrome, and the hyponatremia. So, for hypercalcemia, I want us to just remember the squamous cell carcinoma and the lymphoma, but they have different mechanisms by which they go about that. So, for squamous cell carcinoma of the lung, it elaborates PTH releasing peptide. So, the parathyroid hormone releasing peptide. So, that one can act like PTH. So, it typically comes from squamous cell carcinoma of the lung, although it can come from the that of the head, neck, renal, and all those things. But the typical one that they usually commonly test is squamous cell carcinoma of the lung. So that one is the one that is most commonly associated with this PTH releasing peptide. And if there's elaboration of the PTH releasing peptide, it can act like PTH and it will go to the kidney, it will go to the intestine, and it will cause resorption of calcium there, causing elevation of the calcium to be, to occur, which is hypercalcemia. Then lymphomas can also increase production of vitamin D. So in lymphomas, there's increased production of vitamin D, and that can explain the hypercalcemia. Yes. So lymphomas can, because PTH will eventually stimulate vitamin D production, and both of them work together. So if there's elaboration of PTH releasing peptide, we said it works like PTH. It's going to stimulate vitamin D production. That one will go to the kidneys, to the intestine, and elaborate and increase the absorption of calcium into the blood. But lymphoma don't need to go through PTH. They just produce that vitamin D themselves, and that can explain the hypercalcemia. So we should not forget PTH releasing peptide from squamous cell carcinoma of the lung most commonly, although it can come from other squamous cell type, but most of the time it's from the lung. Then lymphoma can also elaborate vitamin D, and both of them can cause the hypercalcemia. Then the next is the Cushing syndrome and hyponatremia. So both of them are coming from a particular malignancy, and that is squamous cell, and that is small cell carcinoma of the lung. So small cell carcinoma of the lung can elaborate the two A's, which is ACTH and ADH. ACTH and ADH. So if somebody has ACTH increased, they can cause Cushing syndrome. So Cushing syndrome is when there is maybe I think we should leave all those things to where we get there, where we get um to endocrine. So we should just know that the hormone that's elevated is ACTH. ACTH is elevated. In someone that has the squamous cell carcinoma, they can also elaborate ADH. And if ADH increases, there's absorption of water becomes too much. It can dilute the electrolyte in the serum, particularly sodium, and cause hyponatremia because of increased absorption of water. So ADH and ACTH. Hematologic. So we are thinking of polycythemia. Polycythemia is elevated amount or elevated levels of red blood cells. So what is causing that is increased level of erythropoietin. So and erythropoietin can come from so many sources. We want to remember the vessels like hemangioblastoma. We want to remember the liver and the kidney. So liver, kidney, liver, kidney, liver, kidney, renal cell carcinoma, hepatocellular carcinoma, hemangioblastoma. Those are the three commonly tested malignancy or tumors that can elaborate erythropoietin and cause polycythemia. Well, for fibroid, it's fine. Fibroids can also increase it and it can cause polycythemia, although not very common. Pheochromocytoma can also do that. But I feel that if we are able to remember renal cell carcinoma, hepatocellular carcinoma, and hemangioblastoma, we are home and dry with respect to polycythemia increasing, occurring in someone that has those malignancy from increased elaboration of erythropoietin. So pure red cell aplasia and Good syndrome are coming from thymoma. So both of them are hematologic problems too. Pure red cell aplasia just means there's a drop in the reticulocyte count. That is it. Reticulocyte is one that is reducing, that is finally causing the anemia. Pure red cell aplasia, only the red cells, the precursor one. Then Good syndrome is hypogammaglobulinemia. So the problem with thymoma is that when there's a problem with the thymus, the malignancy there's high tendency of the self-reactive T lymphocyte to occur because we remember that thymus is when we have all those negative selection and all these things. So there's disturbance of those selection, and there can be release of the T cells, which are self-reacting. So they can start attacking the bone marrow cells, particularly the B cells, and can lead to destruction of the B cells, then no plasma cell to give rise to the immunoglobulin. So they can have hypogammaglobulinemia from that. So that's the Good syndrome. So once you are seeing hypogammaglobulinemia with Usher thymoma, Good syndrome, we are not saying hypogammaglobulinemia only, because someone that has the Brookston can have hypogammaglobulinemia. Someone that has SAID can have hypogammaglobulinemia. But once you are seeing hypogammaglobulinemia with a mass in the anterior mediastinum, which is thymoma, most likely that's Good syndrome. Although I don't think they can ask this two. Trousseau syndrome is something we need to pay attention to, and that's shared with the pancreatic lesion, pancreatic adenocarcinoma. Because we said that one thing that is peculiar to pancreatic adenocarcinoma is that they are highly clot forming. So they tend to form clots along the entire portion of the vessels. So that's the basis for this migratory superficial thrombophlebitis. Once you are seeing rash, pain, tenderness that is jumping from one body to another, in someone that has a background problem, maybe malignant or something, you are thinking of pancreatic adenocarcinoma being responsible for that. Migrating superficial thrombophlebitis, clots forming in different regions of the vein, causing inflammation of the vein, which is coupled with erythema, which is the typical redness that you see in the skin, the pain, the tenderness, and all those things. Cardinal features of inflammation. Non-bacterial thrombotic endocarditis is also a feature of pancreatic adenocarcinoma, because we said it that these guys can release a lot of clots. So this clot can stay in the heart valve and cause endocarditis. But one thing about them is that it is sterile. It doesn't contain any bacteria, because this is not from bacteria, which is typical for infective endocarditis, an infection. But this is not from any infection. So by the time you culture, you are not going to grow anything. Pancreatic adenocarcinoma is one thing that can cause non-bacterial thrombotic endocarditis. Can anybody among the old guys tell us another disease that can cause non-bacterial thrombotic endocarditis? Anybody? Aside pancreatic adenocarcinoma, that can cause malantic or non-bacterial thrombotic endocarditis. You are going to see deposition of sterile platelet thrombi on the heart valve. Anybody? Okay, so in addition to SLE, to pancreatic adenocarcinoma, SLE can also cause non-bacterial thrombotic endocarditis. Someone that has SLE, they have this similar presentation. So you just see the platelets are just there, fibrin are there, you culture it, you don't grow anything. Non-bacterial thrombotic endocarditis. And one thing about them that makes them very dangerous is that they have high tendency to embolize, unlike the ones with the microbes. These ones, they have high tendency to embolize and cause a downstream ischemia or something. So for the neuromuscular, NMDA receptor encephalitis, anti-NMDA receptor encephalitis, we are thinking of ovarian teratoma. ovarian teratoma, not ovarian adenocarcinoma, ovarian teratoma. So a teratoma in the ovaries, that is a tumor that contains structures that are derived from the three germ layers. So you can see teeth there, you can see hair, you can see skin, you can see muscle. All the three germ layer structures are there. That's a teratoma in the ovary, ovarian teratoma. So what do we see? Problem with the NMDA receptor, you tend to see problem with cognition, number one, very important. There's dementia, then there's psychosis. Those two things you must say it first. So there is memory problems, cortical problems, you know, they cannot do basic executive function, and they have psychosis, they have psychiatric disturbance, they are hallucinating, they're delusional, they are confused and all those things. Then they can have seizures. Part of the cortical function problem is the language dysfunction. They can't speak well. They have problem with language. They cannot use, the language that they are used to. They cannot even speak. They can't talk. Then autonomic instability. But I feel once you're able to remember psychiatric problems, the memory, seizures, and language is okay. Is okay. So for the encephalitis, so we are saying encephalitis. It makes it so all these features we are looking at, they are in keeping with encephalitis, because this is problem with the brain parenchyma itself, not the meninges. And when you see somebody that is presenting with all these memory issues, like the cortical problems, delusional state, seizures, you most likely know that no, seizures is not really specific for that. But once you are seeing cortical problem, memory, the dyskinesia, language, psychiatry, you know that the brain cortex has been affected, and that is encephalitis. Someone that has meningitis will not have all these things. They can have seizures, fine, but they cannot have, they don't typically have language dysfunction. No, it must affect the brain itself, the brain parenchyma, before you can have such disturbances. So by the time we are seeing problems that share with the cortex, memory, language, dyskinesia, most likely the basal ganglia have been touched. Then seizures, you are dealing with encephalitis. Then and that's shared with the ovarian teratoma. So obstacles, myoclonus, ataxia, I said it that day. You want to remember two things: neuroblastoma in children and small cell carcinoma in adults. That is it. Obstacles, they are having irregular movement of the eyes in a non-rhythmic pattern. It's just scattered. That's the obstacles. Myoclonus is they're having jerk, sudden involuntary jerk of a part of the body. Myoclonus. Then ataxia, they cannot work very well. By the time you combine those three things together, you can make diagnosis of a neuroblastoma in the child, or possibility of a small cell carcinoma in the lung. So all these things are actually coming from antibodies. So these guys are capable of releasing antibodies. Like this ovarian teratoma can release antibodies that will go to the brain and start destroying brain structure that has this NMDA receptor. Same with this neuroblastoma and small cell. So they release some antibodies that destroy the cerebellum and some other part of the brain. So when there's destruction of the cerebellum, they can have this subclonus and the ataxia. Yes. So another one is the paraneoplastic cerebellar degeneration. So we should just think of anything that is actually with cerebellar malfunction. So we might not be able to relate very well with all this because we have not done neuro. Yeah, so it's very difficult to be saying. But typical way they present, they have diplopia, they have dysatrial, vertigo, ataxia, all those things are in keeping with cerebellar lesion. By the time we do neuro and we are revising this thing, we'll be able to connect them well. Yeah, so at first now we might not be able to understand them properly, but by the time we are focusing on them in neuro, it will make much sense. So, but for PCD, paraneoplastic cerebellar degeneration, we want to remember three basic malignancy: the small cell, the Hodgkin lymphoma, and the breast. So for the small cell, for the breast express milk. Milk is like yogurt, so anti-yo. Yeah, yogurt. YO. Then the small cell is the one that sticks with the HU. In fact, majority of the paraneoplastic manifestation of this small cell is due to elaboration of this anti-HU. Yes, so we cannot forget it. Then the Hodgkin is anti-TR, anti-HU, anti-YO. So they bind to their corresponding antigens on the Purkinje cells of the cerebellum. So the Purkinje cells of the cerebellum contains the Purkinje cells of the Purkinje cells of the cerebellum express this antigen, the HU antigen, the YU antigen, and TR. So you have these antibodies that are expressed against them, leading to degeneration of the cerebellum. So they can have all those symptoms I've talked about. So don't forget small cell, Hodgkin, breast. So for the breast, anti-Yo, for the small cell, anti-HU, and for the Hodgkin, anti-HR, anti-TR rather. Then paraneoplastic encephalomyelitis. So this is very similar to NMDA receptor encephalitis. The anti-NMDA receptor encephalitis and the paraneoplastic encephalomyelitis is very similar. It's just that paraneoplastic encephalomyelitis is caused by small cell cancer alone. And what you see in the history that will make you think of this guy is that in addition to having this paraneoplastic disturbance, memory, autonomic instability, there's going to be weakness. So when you see paralysis, particularly lower limb paralysis, that's the myelitic component. You can see encephalo, yes, then the myelitis. So in addition to all those things that we are seeing above for the anti-NMDA, there's now paralysis, which is talking about dysfunction of the spinal cord. Myelitis is inflammation of the spinal cord. So, and they can typically present with bilateral lower limb weakness. That's specific for spinal cord problems. They can have loss of bowel control, loss of bladder control, anti-HU antigens of the small. We've said it that anything small cell lung cancer is affecting that is neuromuscular, it is due to antibody against the HU. So that of the paraneoplastic cerebellar degeneration is anti-HU. Part of the paraneoplastic encephalomyelitis is the same thing, anti-HU. Then the last thing you want to remember for small cell carcinoma of the lung is Lambert-Eaton myasthenic syndrome. Very important. This is the most important in this neuromuscular problem, Lambert-Eaton myasthenic syndrome. So there's antibody against the calcium channels at the neuromuscular junction, particularly the P and the Q type calcium channels. By the time we do neuro, we understand all these things very well. This arrangement is not too good. You know, it's kind of a little bit ethic. So antibodies against the presynaptic P and the Q type calcium channels at the neuromuscular junction. That is the Lambert-Eaton, and it is associated with small cell cancer. So there's another one we call the myasthenia gravis, which is antibody against the postsynaptic acetylcholine receptor at the neuromuscular. So neuromuscular junction is just like a junction between a nerve and a muscle. So at the nerve terminal, there is acetylcholine there. So the acetylcholine is supposed to cross the neuromuscular junction and bind to acetylcholine receptor on the muscle. So when the acetylcholine binds to the muscle will contract and the person can initiate movement. So now what is now happening in Lambert-Eaton syndrome and myasthenia gravis is that there's problem with that junction. Is it that we are blocking the calcium channel that is located in the nerve, so that when you block that calcium channels by the use of some antibodies, calcium cannot stimulate the acetylcholine to be released from the nerve terminal into the muscle. So the person will not be able to initiate contraction of the muscle, so there will be muscular weakness. In myasthenia gravis, calcium is released, acetylcholine is released into the muscle, but acetylcholine cannot bind to the receptor on the muscle because they are occupied by the antibodies. That is myasthenia gravis. Both of them will cause weakness, but there are some little differences. So myasthenia gravis, the antibodies are coming from the thymoma. For Lambert-Eaton, the antibodies are coming from the small cell cancer. So what are the distinguishing features? So anybody, the old guys, want to quickly talk about that so that we can move to the next topic for today, which is the last thing in pathology? Anybody wants to quickly summarize it for us? Difference between Lambert-Eaton and myasthenia gravis, please. The old guys, so that we use that one to refresh our memory a little. Hello.
So with myasthenia gravis, so they both involve autoantibodies. It's just where the autoantibodies are. So with myasthenia gravis, you have autoantibodies to postsynaptic ACH receptors, acetylcholine receptors.
Okay.
And then with Lambert-Eaton, you have antibodies, but this one is to presynaptic calcium channels.
Okay. The P and the Q type.
Yes.
Okay.
That's the main thing. Okay, and then
Then
talking
extracurricular
now.
for
So what about the
myasthenia too.
presentation? The presentation.
I know myasthenia tends to worsen throughout the
Yes.
day.
So in
It starts
Lambert-Eaton,
with
there's
weakness.
autonomic instability and then abnormal deep tendon reflexes.
Okay.
And
What Dr. Francois said is also correct.
but in
Okay.
my service,
What? Dr. Morava, what did you say?
in my service, the reflexes are normal.
Okay. I remember I said that in the last class. Okay. Okay. Yes, I think, well, we've
And
tried.
there's no autonomic
Yes, and there's no autonomic
instability.
So there's no autonomic dysfunction
Yeah.
in myasthenia gravis. There's no problem with the deep tendon reflex. So by the time you are seeing deep tendon reflex problem, you are thinking of Lambert-Eaton. And one thing that unifies both of them, they have weakness. And the weakness is usually starting from the small muscle, like that of the face, the proximal muscle. So they have diplopia. Some of them might have problem with facial expression. They cannot swallow, dysphagia. They cannot move the proximal extremities. That's the typical way that they usually. Then they cannot progress to involve the other part of the bodies and even the respiratory muscles. But initially, you just see ptosis. There's drooping of the lower eyelid, because of paralysis of the levator. There's a muscle that we call levator pulmonaris muscle. There's this levator superioris palpebra. So that helps to elevate the eyelid. So that muscle is paralyzed. They cannot elevate the eyelid, so it droops. So there's drooping of the eyelid, ptosis. There's diplopia. They cannot, because of the bulbar muscles, extraocular muscles, they cannot see very well because of the abnormality of the vessel. So there's diplopia. They cannot swallow. Most of the throat, they cannot swallow. Dysphagia. They cannot talk sometimes. Dysarthria. Most of the face, paralyzed too. Problem with facial expression. They cannot move. Their legs, the hip, proximal muscles of the hip, proximal muscles of the upper limb, they cannot do things with those muscles too. Then those are the things that you commonly see with Lambert-Eaton and myasthenia. But what you can use to differentiate them is that if you use Lambert-Eaton muscles repeatedly, the weakness will improve. With repeated stimulation, it improves. But with repeated stimulation from myasthenia gravis, it weakens. So if you try to use it, that's why Dr. Francois was saying, as the day goes by, myasthenia paralysis worsens. But for Lambert-Eaton, as the day goes by and the person is active, it relieves the person. Then in addition to that, you just remember what's it called? Our reflexes and the autonomic responses. Okay, which is compromised someone that has Lambert-Eaton. So autonomic dysfunction like orthostatic hypotension, problem with ejaculation, heart rate problems, sweating issues, autonomic problem generally, you see it in Lambert-Eaton. You don't see autonomic problem in myasthenia gravis. Then the deep tendon reflex are normal in myasthenia gravis. They are not normal in Lambert-Eaton syndrome. So we go to aging and we finish pathology. So aging is just associated with time-dependent progressive decline in organ function, resulting in increased susceptibility to disease. So there is a time-dependent decline in organ functioning that leads to disease. That is it. So what is the molecular basis of this? 3 things that I want us to remember. The molecular basis of aging. 3 things. Genetic, epigenetic, metabolic. Genetic, epigenetic, metabolic. Genetic, epigenetic, metabolic. So what is happening at the genetic level? So telomere shortening. Very important stuff. We studied that there's an enzyme that we call telomerase. Telomerase is an enzyme that helps us to add telomeres to the end of chromosomes of cells that are dividing. As a cell is dividing, there's shortening of those telomere ends at the chromosomes of the cell. And when it shortens to a point, it's going to be recognized by the body has been aged, has been old, and they want to take it out because they feel it's anything that it needs to be eradicated by apoptosis. But some cells of the body have telomeres, particularly the gametes, sperms, and the what's it called? The oocytes. They have it to lengthen their own chromosomes so that they can undergo like uncontrolled, or not, I don't want to use uncontrolled, like prolonged cell division, so that they can maintain their population because they are gametes. Yeah, they are important. Another thing that also upregulate the telomeres is cancer. Like we talked about, hallmark of cancer, telomerase activity, so that they can lengthen that telomere. The body doesn't recognize that cell as being senescent, and they don't take it out by apoptosis so that it can live forever. But with aging, other somatic cells that are not gamete cells, the other somatic cells, they have little or no telomerase activity. So with each division, you have shortening of the telomere. And when it gets to like 50 to 70 division, that's the aphelic limit. At that point, they have to be recognized as being old, and they will take it out by apoptosis. So that is the basis of cell depopulation with aging. That's the reason why cells will reduce in the body because of aging, because of the fact that those somatic cells don't have telomerase activity, and there's shortening of the telomere, and they are taken out by apoptosis once their division has been completed, which is between like 50 to 70 division. Once it's 50 to 70, they take them out, apoptosis. That is all. That is all. That's happening at genetic level. So for the epigenetic, we've said it in BCH. When you see the word epigenetic, it means you are modifying something. Are you acetylating? You are modifying the genome? Are you acetylating? Are you methylating? Are you, those things, demethylating, deacetylating, and the other one? So, and we know that when there's methylation, there is what happens at molecular level when there's methylation. Anybody? When you methylate DNA, what happens to that DNA?
It lives.
Silence it.
Yes, it silences it. So you don't express that protein that DNA sequence is coding for. So DNA methylation typically increases with aging. So there's methylation of DNA, and you silence those genes, and they don't code for, they don't express the protein that they code for. So protein synthesis reduces. Protein synthesis reduce, and you know that protein is it's an integral component of so many cells. So because of that, there's cellular breakdown. Protein synthesis is altered. Protein is a source for enzymes. You don't produce enzymes again. Protein synthesis is responsible for hormones. You don't produce hormones again. Then the last one is metabolic. And the most important of this metabolic abnormality is mitochondrial dysfunction. Very, very important stuff. The most significant organellar changes that happens in aging is mitochondrial dysfunction. So there's ineffective oxidative phosphorylation. You don't generate enough energy. I know that you use energy to drive so many processes in the cell, in the body. And because of that, you have failure of the cellular processes, and the consequence of aging starts setting in. So you want to remember three things: the genetic, which is telomere shortening. That's why the cell number reduces with aging, because of the telomere shortening, and those cells are taken over by apoptosis. There's epigenetic silencing of protein synthesis, and synthesis of protein reduces. There's reduced metabolic activity, because you don't have energy to drive all those processes again, for mitochondrial dysfunction. So let's take the consequence on the organs one by one. So the first one is vascular, the cardiovascular. So one thing I first want us to always remember with respect to this cardiovascular is what? Is loss of the elastin fiber in the vessel. So there is loss of elastin in the aorta. Aorta typically contains elastin within the wall. So that's what makes them compliant. When the heart pumps blood into them, they can stretch to accommodate that blood. That is it. They are compliant. If aging happens, there's epigenetic modification, there's DNA methylation, there's reduced expression of protein. One of the protein is elastin. There's little elastin to occupy those aortic wall. So because of that, the arterial compliance drops, and the vessel becomes stiff, because for it to extend, it needs elastin to become elastic. But when there's no elastic again, it becomes stiff. So aortic arterial compliance reduces because there's an increase in stiffness, and because of the fact that the elastin is not there. What do you guys think will happen to the diameter of that vessel? Will it be more or reduced? You've taken away the elastin. What do you think will happen to the aortic diameter? Will it increase or decrease? Elastin is no longer there, and elastin is a component of the wall. What will happen to
To
the
decrease.
no. See,
Decrease.
no. Diameter. See, elastin is part of the wall. It's part of what is making up the thickness of the wall. If there's no elastin again, that means you have reduced some component of the wall. What will happen to the diameter of that structure? It's not going to reduce. It will increase, because part of what is making the lumen is the wall. I don't know if you get what I'm trying to say. Just picture a vessel. So a vessel is becoming thinner because you have degraded the elastin. What will happen to the diameter of that vessel? A vessel is thinner because you've degraded the elastin. Eh? Do you understand?
Yeah.
Do you get it now?
Yeah.
So the diameter is going to increase. I'm not getting enough response. Do you understand what I'm trying to say? Hello?
Yes.
Okay. That's fine. So the vessel diameter is going to increase because of that elastin that is lost, and of course there's going to be a drop in the compliance too. They cannot stretch to accommodate the blood um, from the heart because of that elastin that is not there. So the arterial compliance reduces, the vessel becomes stiffer, the aortic diameter increases. Now, if the arteries are not compliant, that means that the heart has to work more to pump blood against that resistance. So there's a remodeling of that heart. It undergoes so that means there's a pressure overload now. There's a pressure overload. And if a heart is experiencing a pressure overload, it's going to undergo concentric hypertrophy. And if somebody heart undergoes concentric hypertrophy, there's going to be reduction in the lumen. There's going to be a reduction in the cavity of the left ventricle. So the left ventricular cavity size is reduced. It takes a concentric pattern, and there's going to be segment-shaped intravascular septum. Yeah, it's good to remember that. But the most important thing to always remember there is that there's a concentric hypertrophy of the myocardium due to reduced compliance of the vessel, because they're supposed to stretch when they are receiving blood from the heart during systole. So that's why there's a systolic hypertension in age people, because of this reduced arterial compliance or increased stiffness. It's very, very important. Now, I want to show us something. Because of that hypertrophy, it will get to a time that the hypertrophy cannot overcome that reduced compliance or increased stiffness at the aorta. So there's going to be a backflow of blood that is pulling within that hypertrophied heart into the left atrium. Now, if there's a backflow of blood into the left atrium, I just want us to say, is it going to be a volume overload or a pressure overload? When there's backflow of blood into the left atrium, is that a pressure overload or a volume overload? That's going to be a volume overload. Now, if a heart is responding to a volume overload, they undergo eccentric hypertrophy. Eccentric hypertrophy is quite different from concentric, because in eccentric, you try to arrange the fibers in a series pattern. So it's thinner compared to concentric. So the left atrial cavity size is going to increase. Let me show us so that we can see it with aid of an image, so that we can appreciate what we are saying. So this is So let's look at what it looks like. Okay. So we can see here, this is concentric. We can see that the left ventricular cavity is reducing in the concentric, and we can see the eccentric, which is a volume overload. The cavity size is increasing. So that is it. So because of the fact that what is happening in the left ventricle, in the left atrium rather, is a volume overload from that left ventricle, there's going to be an eccentric hypertrophy. So you just have the fibers arranged in series and they thin out. That's eccentric. But in concentric, they are arranged in parallel, so they thicken. So that is concentric, and that will reduce the cavity size. And with aging, there's this wear and tear, because you are going to have, there's blood flow across the valve for a long time, for so many years. There's going to be some micro trauma to those valves, and that wear and tear process, that micro trauma, is going to cause some little bit of destruction to those valves. And we said it that areas where there is damage, calcium likes depositing in them. So what kind of calcification is that going to be with respect to what we have said now? So aortic and mitral valve calcification happening with aging, what form of calcification is that? Do you guys understand my
Is
question?
it dystrophic calcification?
So is it what?
Dystrophic.
So that is dystrophic calcification, because we have not said that the calcium level is elevated. There is micro trauma to the valve. That's a damage already, and it is depositing in that damage area. That is dystrophic calcification. So it typically affects the aortic and the mitral valve because, of course, the pressure there is higher than on the right side. So they have this aortic and mitral valve calcification, and because of degeneration of the nerve cells in the heart, there's degeneration of nerve cells. You cannot form the protein that can allow those nerves to function. The ATP that they can even use to fire is not being formed because of the mitochondrial dysfunction. So with time, there's degeneration, and because of the fact that nerve cells are not even actively proliferating cells, when their telomeres get shortened, they die of apoptosis. So the destruction of the nerve cells, especially the sympathetic component, causes a reduction in the maximal heart rate. So no matter how much they can stress themselves, the heart rate cannot go beyond a certain point. So the heart rate maximum reduces with aging because of degeneration of the nerve cells. Very important. So by the time we start with reduced compliance of the aorta, increased stiffness of the aorta due to loss of the elastin, we'll be able to take it from there. So with that, there's going to be hypertrophy of the left ventricle, reduction in the left ventricular cavitary size, there's overload of volume to the left atrium, causing eccentric hypertrophy to the left atrium, which brings about an increase in left atrial cavity size. The microtrauma to the aortic and the mitral valve causes the mitral valve and the aortic calcification, degeneration of the nerve cells, the nerve fibers, causing a decrease in the maximal heart rate. For the gastrointestinal, now this thing at the end of the day for the cardiac is going to bring about a reduction in the cardiac output. Yes, so there's going to be a reduction in the cardiac output. So blood flow to so many organs will be reduced. That's another problem with aging. Now let's go. So for the gastrointestinal, there's going to be a drop in the lower esophageal tone and reduced colonic motility. These two are due to reduced nerve activity, degeneration of the nerves, particularly the vagus nerve. Vagus nerve is one that is maintaining those tone as well as the colonic motility. So vagus nerve is what is helping the colon contract for peristalsis. So with that, degeneration of those nerves is going to reduce the colonic motility as well as the lower esophageal tone. And there's going to be a reduction in gastric mucosa protection because of the reduced perfusion to the stomach. Because in people that are aged, there's cardiovascular remodeling, reduced cardiac output, reduced perfusion to the organs. The gastric mucosa is one of them. If you check, one of the things that causes ulcer is when somebody has reduced perfusion. That's the basis for stress ulcer. I hope you guys remember the old guys when we say stress ulcer. Do you remember cooling and the Cushing ulcer? Hello?
Yeah, post-born.
Yeah, so one is due to trauma, the other one is due to burn. So the trauma one causing ulcer is due to the fact that the blood loss from that trauma is reducing perfusion to the gastric mucosa. So that is why they cannot have nutrients to renew the mucosa. They cannot have nutrients to, supply the mucus, because the mucus that is protecting that mucosa is containing mucin, which is a protein, and you need blood flow to deliver the nutrient to produce more mucin. You need blood flow to even deliver nutrient to allow proliferation of the epithelial cells, which lines the mucosa. So when there's reduced blood flow, you have reduced gastric mucosa protection. So they can be susceptible to developing ulcers, erosive gastritis, and all those things. So don't forget, the nerve one is causing reduced colonic motility as well as lower esophageal tone. For the hematopoietic, I always want us to remember, I don't know if you have come across it in pharmacology. What happens to the fat mass in people that are elderly? Anybody? I don't know if Dr. Babarinda have talked about it in pharmacology. Fat mass in elderly people. What happens? Have we talked about it?
Increases.
It increases. It increases. There's no metabolism. Those guys have a very low metabolic rate. Mitochondrial dysfunction. There's a low metabolism. They're not metabolism fat. They're not even moving. They're not doing rigorous work. So their fat content increases. So there's fatty infiltration of the bone marrow. Because of that, there is destruction, or there's a reduction in the cellular component of the bone marrow. So all the hematopoietic stem cells there, they are replaced by the fats. So there's a reduction in bone marrow mass. All the cells that should be producing the blood cells are reduced, and there's increase in the fat. So because of the reduction in the bone marrow mass, you have less vigorous response to stressors. So if there's blood loss now, and you should have almost immediate proliferation of the hematopoietic stem cells to replace those lost cells, like the white blood cells, the platelet, and the red blood cell, it doesn't happen because the bone marrow mass has been reduced with aging due to fatty infiltration. That is it. Immunity. So with respect to immunity, I just want us to remember that it typically affects the adaptive arm, not the innate one. So the major effect is on the adaptive, that is the B cells, the T cells, and the antibodies that they produce. But with respect to even this B cell and the T cell, the one that is predominantly affected is the naive one, not the memory. You will see it in a question. You see it in a question. I'm going to show us the question now. So the memory ones are still preserved because they live longer. You don't need to replace them often and often. But the naive one, they have a short lifespan, so you need to replace them time to time. Yes. So that is why the memory component of the B cells and T cells are preserved, while the naive ones are reduced. And that brings about the concept of immunosenescence. So immunosenescence just means that there's impairment of the immune cells to respond to new antigens. Take note of the word new antigens. And what are the ways by which you can deliver these new antigens? By exposing them to infection or vaccinating. So it means that if this person has 1 billion memory B cells, do you think if we expose them to new antigens, will they be able to mount immune response to that antigen? Anybody? Even if they have 1 million memory cells, will they respond to exposure from new antigens? And their naive B cells and T cells are down. Will they respond?
No.
No.
Why? Why wouldn't they respond? Why?
I think 90 cells are need to differentiate into T helper cells for proper antigen presentation.
Okay. So, but what about the fact that we have 1 million memory T cells and B cells? Why is that not helping?
I think the antigens still need to be presented to these cells, even if they are memory cells.
You are not saying it well. Look at the word. You guys, hello. Do you guys want to try? You guys should try now. I want more suggestion.
Because apoptosis is no more taking place or something like that, then there is a lot of memory B cells and T cells that are not dying off. And then
Okay, so if they are not dying off, if I've not exposed them to new antigens, why is there no immune response? Okay, so when we say memory B cells, they are memory cells. They are having record of a previously encountered antigen. Now, if you have memory B cells in the body, you are now exposing the person to a new antigen. You have not produced a memory B cell to that antigen. So there's nothing to respond to it. Because these memory B cells are B cells against an old antigen that they've been exposed to. If you expose the person to a new antigen, your memory cells cannot respond to it. That's the concept of vaccination. You vaccinate a person against a specific antigen now, so that the person can have a memory B cell against the antigen, such that when that same infection that contains the antigen comes again, your memory B cells can respond to it. But if somebody has so many memory B cells and the person is now getting exposed to a new antigen, they will not help, they will not do anything. Please, I hope what I've said makes sense to us, or should I come again?
Yeah, it makes
Yeah,
Come
sense,
again.
but
we get it. We get it.
Hello?
yeah, but it makes sense. But you made this first time you were asking, made it seem as if it's the same pathogen that the memory B cells were what's it called exposed to.
No. Look at the way I asked the question. I said, pay attention to the word new. I said, you are exposing somebody to a new antigen and you have 1,000 memory B cells and reduced naive B cells, and you are not still having an immune response. Why? That is the question. Why? Hmm? So I don't think
Okay.
I twisted it. I did not twist it though. So I think some people said it's not clear. Hello? Hello?
We can hear you. Well, I don't know if I'm the only one that cannot see your screen anymore.
I'm coming, just 1 minute. One